a different computer today. And
Can't hear you, Doctor.
very good. Okay. So if by some chance that I lose you or I start fading out, please let me know. This will be, I think this is the last class I have with you guys. So y'all are getting toward the end of the program. And so it's, it will be, but you guys always have access to me if you have a question or anything like that. Do not, well, I appreciate those comments, everybody. I've enjoyed your class. You've been one of the better classes that I've taught from a standpoint of being patient with a lot of things, but more importantly, I've enjoyed your comments and your humor. You'll probably get to hear Big Al lap up his food, and right now he's decided to go plop down, so you'll probably be hearing him snore a little bit. So that's probably it's going to be there. But like I said, is that as you go through the program, if you have questions or things that come up, do not hesitate to drop me an email. And please, sort of let me know. Let me know if you guys if you pass the exam and so forth. I always enjoy finding out when you guys have made it through there. So that would be super. Well, what we're going to do today is we're going to talk about some chronic diseases. So this will be not as dense as some of the other lectures that we've had. We're going to go at a little bit more relaxed pace, I think. And a lot of these we've touched on a little bit. Some of this is common sense, but it does address an issue with regard to a lot of issues that come up with regard to chronic diseases. I know our pharmacy students for so many years, we talk to them and we tend to partition things out, like here's a hypertensive and here's a person with depression and here's a person with this. Interestingly, we find that it's very difficult to find faculty to include people with some of the mental health disorders. And this has become more and more of an issue. Just interesting thing is one of the people that I do Krav Maga with is a police officer. And we've had 3 or 4 shootings this year, fatal shootings. Police officers have shot somebody, and on each instance, it has been a situation where it appears to be, suicide by police. The Clark County, the county that I live in, has now got a grant which will increase the training of police officers with dealing with mental health, as well as try to bring a professional with them that is a psychologist or a social worker that has experience with dealing with that. But it just emphasizes to us, I think a few years ago, our initial issue would be, this is somebody high on drugs. But now we're finding that it's not necessarily that they have, we still see occasion, for example, with meth addicts and stuff like that. But the last 4, I do not think that any illegal drugs were involved, or at least the people was not taking it at that time. But it's going to be, it's a big issue that's there. But again, it just emphasizes the need for more help, for more understanding, and more people to have an understanding. One of the things with the police officers that they've dealt with, and they've released the body cams, and I've seen several things, is that it's just, we see one is that these individuals, we have a lot of people that are saying tase these individuals and things like that. And the thing about it is people don't realize sometimes that the tasers don't work. On 2 of the individuals, they received, shots to the trunk and still got up and kept coming with machetes and a knife and I think an axe. A couple others were involved with pistols where that's there. But let's move on to today's material here. But I just wanted to emphasize to you, what you guys probably ought to know is the big concern with mental health here. So let's look at, when we look at chronic diseases, if you look at what are classically fall into these chronic diseases, typically we have cardiovascular diseases, and these include atherosclerosis. These include, hypertension. We also have some congestive heart failure, even arrhythmias like atrial fibrillation. That's one of the diseases. Diabetes. Many times, a lot of these diseases we're not dealing with being able to cure. Okay, so we're dealing with long-term therapy with a lot of these individuals. Diabetes frequently is going to be associated with obesity and cardiovascular disease. We do have obesity. We do consider that a disease. We have chronic pain, which I think most people are aware of, with all of the emphasis with regard to the emphasis on the opioid epidemic. But again, not only do we have an opioid epidemic, but we're seeing a lot of prescription drug issues that are coming forward. Another thing that's coming about is CBD, with regard to the CBD has become more and more of an issue with regard to people trying to use it instead of using the opioids. I don't know if you guys have done that, have seen an increase in CBD, but one of the things, I may have mentioned this to you guys, I think I did, but just in case I don't, because I just ended up talking to a nurse that was wanting to use this. Be aware that with CBD that you can test positive for marijuana. And so we've had a couple of instances. I've had one in particular where an individual lost their job because they were prescribed CBD, and they were in a school system and basically broke up a fight when they were drug tested. They tested for marijuana, and therefore they were fired. There was no discussion with regard to where it came from, or even though with documentation from the treating healthcare professional that had prescribed the CBD, they just ignored it. So it's one of the things that the nurse that I was telling you about, her husband's a police officer, and he and several others are like, they've been told don't even use it because if they fail a drug test. Yeah, Angela, that's an interesting thing. It says no THC, but the point becomes is, first of all, I'm going to send you guys, you may find this, I'll send it by Aiden, but there's a report with JAMA, the Journal of American Medical Association, I think came out with regard to where they went and measured various products on the internet available commercially. And they found a wide range of situations associated with whether it contained no CBD, contained only THC, contained CBD, but less than what was there. So yeah, Angela, that's the thing is that we've had patients argue that too, but it is just not regulated. The other substance that is, I just had a case this week that showed up, is kratom. We just had a lady who was in a wreck. She was transporting her children and was in a wreck, and she was on a number of CNS depressants, including kratom. And even though the way I put it is kratom is not legal, but it's not illegal in a lot of states. I was in South Carolina a few weeks ago, and there was ads for CBD and kratom all over the place. So these are things that'll come up too. But the THC is, even with Epidiolex, which is a plant-derived CBD product, even their product literature says that you could test positive for marijuana. So today, regardless of what people tell you, to my knowledge, there is no way that we have, although they derive it from hemp, there is still maybe some THC there. And according to the law, most states say that the THC has to be below 0.3%, but the point becomes is who actually is testing it and that sort of thing. So it's what I usually are telling people when they give me the same answer Angela, I just tell them is buyer beware. You know, the guy that was with the school system, the situation that came up with him was basically that that there was, you know, his was prescribed and came from a company that touts very regularly or very highly that they have high quality control. So we don't have a process right now to completely remove it. And then depending on which commercial product they get, there may be more THC on it than there. You know, what happens is, just like the FDA has sent out letters of warning to some of these companies, and they just tell them to cease and desist from selling or from marketing, you know, as a cure for certain things. But the companies really, you know, there's not a lot of regulation in what they do. So they can ignore it or they can take time to fight it. So it's just one of those things you need to be aware of. But with chronic pain, everybody is always looking for alternatives to the opioids. And there are some alternatives, but it may not work on everybody. So be aware of that. And then we have alcoholism and drug addiction. Have you guys had has Meryl Norton lectured to you guys yet on substance abuse? Okay. I think that one's coming up. I think you'll enjoy Dr. Norton. He's a close colleague of mine. And if something happens where Meryl isn't able to lecture, then that may be where you might see me again. But Meryl is well known in this particular area. And then the other thing, which is some people don't like to consider, that is basically age. So as we get older, we have things that change. Some people consider aging a disease. Some people, you know, basically is considered a natural physiological component there. So but we have to take into account, and then keep in mind that as we, you know, as we basically age, we have more diseases. So that adds typically more comorbidities, and it also adds more drugs typically. So when you look at the World Health Organization, they actually have a list of what they consider chronic diseases. One of them people don't think about is visual impairment and blindness. A lot of people consider as you get older, you're going to lose your eyesight. We do know that there are people but sometimes with our technology, with glasses and contact lenses and so forth, there's, and all the surgeries that we do for glaucoma, visual impairment and blindness becomes a chronic disease. You know, I'm developing I have the start of a cataract in one eye. And so, you know, I can see, you know, changes in my vision. I noticed it when I first thought that when I had LASIK done that it just needed to be improved. And when I went to get it to check, figured I needed it tweaked, that's when they discovered I had a little bit of a cataract developing, which now what they do is you can have cataract corrected and then go back and have LASIK done, or a lot of people will have the cataract corrected, and when they replace it, they go ahead and put a corrective lens in there. But visual impairment, we'll talk a little bit about that. World Health Organization includes cardiovascular diseases, diabetes. Here's another one that wasn't included in the original list I gave you, was pulmonary diseases, asthma and COPD. Many people that develop asthma and COPD struggle with this. I mean, sometimes with asthmatics, people, they will talk that they may outgrow it, or some people may think about it. But just in managing these, especially with COPD, we run into a particular issue. One of the things that we're seeing as a new, quote, epidemic that's starting to emerge. How many have y'all heard about the stuff with vaping, as far as pulmonary issues associated with that? I just was interviewed recently dealing with vaping, and one of the things we saw was when vaping emerged, this was promoted very heavily as a safe alternative to smoking. So we had a lot of people that targeted or that shifted from smoking to vaping, thinking that this was entirely safe. We also, Juul, J-U-U-L, the company that puts them out, is under a lot of fire in the fact that there's a question of whether that the vaping may have picked up where someone is actually smoking more because they think it is. So Janelle, with your question, what is worse, vaping or cigarettes? Both of them come with some significant things. One of the things that we're seeing now is there is a, have y'all heard of this drug, of this condition? Let me put it up here. Have you heard of EVALI? Okay. So how about this? Popcorn lung. Okay. So what we saw was the FDA has, the CDC has been monitoring a lot with regard to vaping and pulmonary illnesses. That EVALI was just recently the syndrome that has been associated with vaping. And what EVALI stands for is, let me see if I can get this back here. So EVALI stands for e-cigarette vaping associated lung injury. So vaping, it has now been given an official name. The problem has been that the people that have shown up with these problems, what they have seen is that it's really been a diagnosis by exclusion. They've ruled out everything else, and the person vapes, and then they rule out everything else. And a lot of times it may go unnoticed because somebody comes in with some pulmonary problems that could be associated with various other things. So what they do is popcorn lung is also known as bronchial obliterans. And it's not that the lung looks like popcorn. Some people, students, when I've lectured to them, they think that the lungs are sort of flared out like popcorn. What popcorn lung came from was really that there was there were factory workers in a popcorn factory that were using a butter flavoring agent, which created very unique lung injury, which is similar to what we see with vaping. So the letters stand for e-cigarette vaping associated lung injury. E-cigarette vaping associated lung injury. If you Google EVALI now, the CDC has now got that. But anyway, what we're now seeing is what we do know right now is they're still looking for common denominators, but it appears that right now the most common individuals that are emerging with this EVALI are males, males more than females, but males seem to be preponderance, and all of them have used THC. Again, we're still gaining data on it, but these are dealing with the ones that have died. Some of them have used THC and nicotine. But the other thing that has occurred with this vaping has been that a lot of the flavorings, the companies that put these out have said these are used in food, so they're absolutely safe. And the argument is that, yes, they have been used in food, and they are considered safe, but there's a difference when you are, think about this, you drink water, but if you inhale enough water, you can choke. So what we found is some of these flavorings, some of these constituents that occur as a result of vaping. Sometimes we have where the coil will sometimes release heavy metals. So we do see that there's a lot of unique things that are occurring that can cause significant lung injury. So with asthma and COPD, which a lot of those were associated, I mean, we have several cases associated with people smoking. A lot of people were thinking with vaping, this is going to decrease, and we think that actually we may see another group of patients that are, showing up with vaping. Obesity, as I mentioned before, we do have a big issue with obesity. Alcohol, who lists alcohol? They don't list substance abuse. They also list cancer. And we do see people that have multiple cancers. We do see people that have incurable cancers. And then we see people with things like sickle cell disease and other hemoglobinopathies or some sort of pathology associated with their hemoglobin. So these are, so what I'm going to do is, again, I'm not going to test you on these things, but I will send you some information, which I think may be helpful to you. So I'll send you some information on the CBD, and I will send you a little bit of information on eValley. So what I'll do is I'll post those on Moodle for your information, but not from a sense of testing, okay? So one of the big things when you're looking at chronic disease, chronic drug therapy, so there's a lot of things we take into consideration here. One is with chronic drug therapy is we're looking at a scenario that, with chronic diseases, many times we're looking at chronic drug therapy, okay? The other thing we need to realize is that with multiple chronic diseases, even when a person has a chronic disease, if they get an acute disease, such as maybe they get a virus or something like that, that can have a lot more issues associated with it than if they didn't have that disease. So, but looking at a chronic disease by itself, what we have to look at is that with a chronic disease, it's going to progress, okay? Drug therapy many times is not going to cure it. We may have, the disease is typically going to progress. Many times what the drugs may do is the drugs may slow the progression of the disease. But ultimately what will happen is we typically will see that the disease progresses. And that's assuming that somebody basically is being compliant. That's another issue that is coming up there. All right. So during this chronic drug therapy, we're going to see, not only do we have progression of disease, but keep in mind that as the disease may be progressing, what we may be seeing is the person is going to be aging. It's not that we may see it, we are going to see it. That the person is getting older, so age-related changes get amplified or may potentially amplify the progression of the disease. So our ability, for example, our liver and kidneys, let's look at kidneys. If we've got a disease going on and then we have a naturally age-related decline in kidneys, then that's going to affect our body's ability to manage the disease, okay? Now, the other thing that's going to happen is any drugs that we use, we're going to have altered pharmacokinetics. Let's look at disease. Let's leave aging out of it for right now. So one of the things that's going to happen is that as the disease progresses, changes in liver and kidney activity is going to change. That's going to affect metabolism. Our GI tract, if we have altered GI blood flow, if we have altered GI motility, if we have damage to the lining of the GI tract, that might affect the bioavailability. The difference in how much acid we produce may affect bioavailability. And remember, bioavailability is referring to how much drug gets actually taken up into the bloodstream, okay? Metabolism. So let's take somebody with cardiovascular disease. As the cardiovascular system is altered, what we're going to run into is that blood flow, the viability of the vasculature to particular organs, for example, the stomach, the intestine may change. So that can affect bioavailability. Our metabolism is potentially changed. Our liver, with the disease, if it's producing liver damage, it will reduce our ability to metabolize. Protein binding. If we have liver or kidney disease, that can affect the production of proteins as well as we start getting leaky kidneys, and so we start getting loss of protein. The other thing that you're looking at is that as the disease is changing or progressing, is that that person may not be eating as much. So changes in nutrition that may occur can affect our ability to make proteins. So these are things that will come into play too. We have to consider that there may be altered pharmacodynamics, okay? Altered pharmacodynamics, what we can run into is that the disease, you guys will see this, for example, when you're using anticonvulsants. If you're using those as mood stabilizers, those drugs can induce metabolism. So what changes is that in using a drug that may change the metabolism so that alters how much drug is going to be delivered there. Altered liver and kidney function can also ultimately affect pharmacodynamics, how much drug is going to be delivered. We may see that a disease may alter the receptors that are available, or alter the neurons that are involved with the receptors. So those are things. We also have to be careful because we can see an emergence of side effects, okay? So as people are on these drugs for longer periods of time, one of the things we have to look for, a good example of this would be, say, somebody that is on a drug, an antipsychotic. One of the things that we always have to be aware about is the emergence of things like extrapyramidal symptoms, EPS, or tardive dyskinesia. And then we also see that as we progress, is basically one of the things that's going to happen is we may potentially have drug interactions. Keep in mind with drug interactions is one of the big times that people sometimes forget is when we're changing drug therapy. So when we're changing drug therapy, one of the big issues that we run into is like we stop a drug and we have to let the drug they were on clear out. So sometimes with the overlap of the drugs, that can create a problem. Also, if there's acute situations where somebody may get an infection or something, or we may need to use a drug for a short period of time, that can create some potential drug interactions. What I always say is that there's five. I think there's five. I'm going to give you these because I mentioned them before. When are we most likely to see drug interactions? And I'm going to put them on the chat board here. Is when you add or delete a drug from therapy. Okay, that's number one. You add a drug, obviously you might get a potential drug interaction with something that's on there. When you take one away, sometimes what's happened is that the drug may have altered the metabolism or may have been competing for the drug as far as protein binding. So anytime you add or delete a drug, another thing is change in dosage. So these are times when that's a change in dose in any drug. So these are the times to look for drug interactions and potential side effects. Add or delete a drug, change the dose. Those are two prime times when to be aware of it. And sometimes people don't think about it. They think more of an issue of if they, if they just add a drug or increase the dose. But sometimes decreasing a dose can sometimes result in a different side effect. All right. So when you're dealing with people and you're dealing with these chronic diseases, one of the things that you guys have to always be aware of is that let's talk about mental issues. So one of the things that we have to worry about is that when we start seeing some emergence of mental issues, one of the big things comes into play is whether this may potentially be a psychological issue or a pathological issue. So for example, when someone starts having a psychotic reaction, one of the big concerns is that could it be a problem with liver function, which causes metabolites to build up, such as ammonia, which may produce an encephalopathy? Could it be, for example, confusion or malaise or things like that? Could it be, is it a cardiovascular disease that may be altering blood flow to the brain? These are things to determine, and sometimes we tend to limit or try to box that in depending on our therapy. So a general practitioner may be not thinking so much as psychological as if, for example, with somebody with high blood pressure, whether it is more of an issue where that their brain may be affected by the changes in the blood pressure, or a person with congestive heart failure that the person's effects may be there. The other thing that we see is are there pathological are these, what potential pathological complications? Basically, is the disease changing my liver or kidneys? Is the disease changing cardiovascular? So look at cardiovascular. If something is happening where my heart is being suppressed because of the disease, maybe I've got decreased cardiovascular function, then one of the things may be happening is I may have decreased liver flow. I may have decreased renal blood flow, which could be affecting how the drug is producing its actions. So these are things to be aware of. Endocrine changes, thyroid, adrenal gland, these can have big changes there, okay? And then what we have to consider is over the period of time, looking at both chronic disease, and let's look at age as a common thing, is when we start giving drugs and manipulating drugs, what effect does it have? Do these changes, does the pathology affect the drug therapy, or does another drug affect the existing therapy that we have? And then when we start seeing things, sometimes what may happen is we may get a change where that if we start seeing an effect, we have to determine, is this a drug effect, side effect of a drug, or is this a drug effect, or is this an effect where the pathology is getting worse? For example, somebody may suddenly start developing more memory loss or dementia type reactions. And one of the questions may be, is this due to a dulling effect of a drug we're giving, or is it due to the progression of the disease? And these are sometimes very difficult to stretch out. And one of the things that we try to do is we try to focus sometimes on the concept of when did we get the drug? Does the drug produce that particular side effect? Okay. Another thing, changes in hematology, such as anemia, changing in our red blood cells, particularly. A lot of diseases, some drug effects, especially CNS depressants, fatigue and dizziness may be a side effect. But we also see that can be produced by anemia. So if the disease state is damaging or affecting the red blood cells, we got drugs like Clozaril or things like that. These can be important things. Changes in lung function can affect our ability to deliver oxygen. Damage to hemoglobin. So a hemoglobinopathy may damage or may produce some effects such as fatigue and dizziness. And then the other thing sometimes is anemia can produce tachycardia, but sometimes individuals may be thinking they're having a panic attack because their heart rate is speeding up. Things in the cardiovascular system, atherosclerosis blocks the blood vessels up in the brain. Arrhythmias were going to interfere with the effective pumping of the heart and distribution of blood. Congestive heart failure is going to decrease the amount of cardiac output, which can affect our kidneys, which can affect our liver, but can affect our brain. Stroke or hypertension can damage the blood vessels. The net effect is alterations in cardiovascular function can affect the brain so that it's not getting enough oxygen, which can produce impaired cognition, fatigue, dizziness, headaches. It can affect the liver or the kidney, which can result in a buildup of metabolic waste products, which can produce these effects. And then hepatic dysfunction, again, things like encephalopathy. So damage to the liver can result in a buildup of ammonia and metabolic waste products. We've mentioned the kidney. And then endocrine, don't rule out, and this is probably one of the bigger ones, is certain mood disorders and impaired cognition can be associated with endocrine disorders. But when you look at endocrine disorders, really the only one that gets checked on a regular basis is what? Which endocrine system do you think gets checked? It's thyroid. And thyroid can produce mood disorders. Thyroid can alter impaired cognition. All of that can occur. But, the adrenal gland can do, we can have other systems, other endocrine organs that may be affected, but those may not be. It's not uncommon to run a thyroid screen, but some of the others, and endocrinologists are some of the hardest people to get into to be able to see. So that makes it an important issue to come into play there. Okay? So these are some of the pathological, and we've sort of touched on these, but these are just spelled out a little bit more. So cardiovascular, we worry about poor perfusion of the brain. Less oxygen can produce some CNS effects. Poor perfusion of the liver, we're going to have impaired metabolism. And that's, when we talk about impaired metabolism, we're also looking at not only of drugs, which can build up, but we also are talking about metabolic waste products like ammonia. Sometimes some hormones may not be broken down like they should have been, okay? And for poor perfusion of the kidneys, which we know that as you age, there is a reduction in the blood flow to the kidneys. We see sometimes a 20 to 25% decrease when you start getting up in your 60s and 70s, okay? So with the liver, metabolites, and again, with metabolites, include drugs as well as other compounds. One of the major functions of our liver is going to be to primarily break down metabolic waste products. If those metabolic waste products build up, then they can have detrimental effects. Impaired drug metabolism, but another thing about liver is it's going to synthesize, for example, carrier proteins, albumin. If the liver is damaged, it's not going to make these things. And so if you have a drug that's highly protein bound, one of the big things that you got to worry about is that you have less protein. So for a given drug, you're going to have more free drug, which can produce a greater effect. Okay. The other thing that we have to consider in today's time is that malnutrition. Now, when I typically talk about malnutrition, most people are thinking about homeless people or the poor or third world countries. But keep in mind, we have a lot of our middle class people that basically will go on fad diets and things like that. And then Eddie, you mentioned an important thing there is alcoholics. They're not going to drink. Drug addicts are not going to eat. So we can't limit when we talk about malnutrition. Think about people that are in fad diets. I mean, right now, keto diet is the big thing going on. And a concern is that sometimes people going on the keto diet is that there can be some major concerns with these particular people. This is a good example of something else. How many of you have heard of the keto flu? So a person that's going through that, if you're not aware they're on a diet, that could be a big issue that could come into play there. And different diets and different things may have different expressions. Here's another one is people that are just getting their flu shots and shingle shots and things like that. Those individuals can go through a period which is a flu-like appearance, but sometimes those people may just become very lethargic. They may just be really way down and stuff like that. So let's see. So two things there is, one is that with comments there is, one is that there is a condition with the keto diet that as your body is changing its metabolism, and that's literally what the keto, a lot of people like the keto diet because they hear all these people that lose a lot of weight. But the point is that we can see that many of these people will have mood lability. So their moods go up and down. We find that there is the component of the keto flu typically is going to occur within the first week. And so what those individuals will typically complain of is they ache, their mood may be down, they have no energy, they act just like you have a flu. That's why it's referred to as the keto flu. And that's where there's a change in metabolism there too. And then Kara, you also mentioned like that is that when you change from sugar, you know, what you're doing is when you look at that, basically you, your body is shifting from a different, so instead of using sugar, you know, having sugar in your diet, your body is going to be breaking down fatty acids to form ketones. And so what you see is, what you will find is that you will see some of these effects that occur. So sometimes they typically are going to last just a few days, but we also see when people start changing their adaptation that can occur. But we also see changes, as Gareth was saying there too. We also see individuals that, you know, when they go on or start binging with a lot of sugar, we're going to see a lot of mood changes that go there. So changes in diet can affect a person's energy level. They can affect their mood. They can affect their, we can get some dysphoria. We can get some big fluctuations in mood, which can sometimes be a concern with regard to, especially if someone has some other underlying conditions. And then we mentioned with the kidney already that you can get a buildup of metabolites and waste products. One of the things also that you have to be aware of is electrolytes. So electrolyte imbalances, sodium, potassium, calcium, chloride can result in big changes in how a person is acting, how a person's psychological effects are. With renal damage, you can get some fluid accumulation. So you start getting edema. That fluid accumulation can produce some bloating and things like that. So that's a concern there. And then, and sometimes this fluid accumulation can make your blood pressure go up and can make some other changes occur. So a lot of the things we've talked about over the course of these curriculum is you would see can have some impact here. With endocrine, our biggest thing is, in addition to the hormonal changes that occur, we may see electrolyte imbalances, which can, in some instances, we want to be concerned about because an electrolyte imbalance could produce a situation where that, you know, for example, if someone was on a drug that may affect the heart rhythm, then electrolyte imbalance may put them at a higher risk for that. One of the big things that people forget sometimes is we promote staying hydrated, and we have had people that have drank a lot of water. And one of the things that'll happen is they may be getting up at night, going to the bathroom a lot, and therefore they're fatigued the next day. So they may come in complaining of fatigue and not sleeping and that sort of thing. And maybe a big change may simply be a change in the amount of fluid intake. It's not only water, but other things that are there. So that's a thing that we consider or we worry about, okay? Drugs like citalopram and some of the others, some of the antipsychotics can change the QT interval. Changes in electrolytes, especially potassium, may accentuate that. Okay. All right, so let's talk a little bit about this. Let me see something real quick. Yeah. So let's talk about this slide, and then we're going to give you guys your first break this morning. All right, so one of the things that we try to do, and hopefully, you know, we've emphasized this to you over the curriculum, is that when you have comorbid pathological conditions, which could include age, that often is, we're going to make our therapeutic choice, and you're going to learn to do this, and several of you already are doing it. The idea is that by knowing what my patient has, then that is part of the risk assessment, risk benefit that I've got to factor in. So how I choose or what drug I choose will depend on when I have a person with multiple conditions, which often is occurring with people with chronic diseases, then I have to consider, when I'm treating one disease, I have to consider what are the implications, what are the risks of the other disease being present, okay? So, for example, one of the things that if I have a person that is in psychosis, I want to be careful about giving them a stimulant. Even a decongestant can create a problem because it could actually accentuate that condition. If I have a person with severe heart disease, that has ADHD. I want to be careful because if I give this drug, I could actually exacerbate that. So by having a chronic disease or comorbid pathological disease or pathological conditions, that's going to really dictate. I've got to consider all of those. Even though I'm not treating one, let's say the person has diabetes. I'm not treating their diabetes, but let's say that I'm going to treat them for, for a specific, for schizophrenia or maybe a mood disorder. And one of the things I have to consider is basically, is the disease, if I'm going to use an antipsychotic, is it going to make their diabetes worse? Or let's say I have a person that's obese and I want to put them on an antipsychotic. One of the concerns I've got to have is my drug therapy going to accentuate their obesity? Those are concerns that you're having to do with. Every time you prescribe, you have to consider the comorbid conditions. You have to consider the age of the person, if we separate that out from comorbidity. You have to consider what other drugs they're on there. And one of the things you're going to run into is many times if somebody else is prescribing something, let's say the person is being prescribed something for their hypertension, and you're going to prescribe something for a mental disorder. The person that's prescribing the hypertensive, and they've got their hypertension control, is not going to be necessarily receptive to changing their therapy when they're treating them. So, and Najib, that's right. For example, when you talk about, you got to be careful when somebody giving citalopram to a person that has an arrhythmia, because it can cause arrhythmia. The dosage, there's a big difference between, if we're dealing with we need to get control of something with somebody that has a severe psychosis that's going on, we might use a larger dosage versus if we've got something we can take time. Sometimes we may be titrating up. Maybe we're going to change drugs and we need to make sure the other drug is titrated down. So the choice of drug we pick, as well as the dosage, is going to be dictated by the comorbid conditions, and associated with those comorbid conditions, if you include age, if you separate age as not being a pathological condition, it's going to include the comorbid conditions, the age, and then you're also going to look at probably the drug interactions, the other drugs that are being used to teach that. So the other thing, when you're making changes or even starting therapy, you need to determine up front whether a person is experiencing a side effect of a drug, or maybe there is a pathological state that's going on. So a person walks in and says, look, I'm not sleeping. I just can't stay asleep. So the tendency is going to be, okay, well, let me give you something like Ambien. Okay, that'll help you get to sleep. Well, if I've done my due diligence, I may find out that the guy was just started on a antihypertensive drug, such as a diuretic, like a thiazide. And the reason is he's taking his medication at night because he doesn't like going to the bathroom, or maybe his job makes it difficult for him to go to the bathroom during the day, so he takes the pill at night. So what we're going to see is going to be a situation where you've got to, you may, instead of giving him Ambien, because the main thing Ambien might do is have him just sleep in his bed anyway. But we need to really find out, is this a side effect of a drug? Is it where maybe this guy's got bad kidneys and he's not on a thiazide? Those have to come in there. Arnold, when you ask that question about what is the proper phrase, it depends on the different drug, and different people like different things. So a lot of times we see, we tend to titrate up, and you can even say titrate down, either ones. So, but taper or titrate basically are, typically they'll say titrate up and taper down, but you're basically titrating down on that too. So either phrase can be, but typically we'll hear people say titrate up and taper down. Yeah, but titrate is the correct term there. Okay. So we need to evaluate, when somebody comes in, we need to evaluate, we need to do that as part of our overall assessment of the patient of what's going on. Okay. Here's the big thing. Here's the thing you need to be aware of. If you have a person with comorbid pathology, comorbid conditions, then basically that's going to dictate closer monitoring of that patient. It means that you need to pretty much be, on a patient with a single condition that's stable, you might see them every 3 months. A person with comorbid pathology, a lot of people will want to see them probably every month, every 6 weeks. And again, depending on what's going on and the state of that, could make a big difference with regard to specifically what you're looking at there. So keep in mind that the more things going on, it just makes sense, there's more to go wrong. So what you want to do is you want to monitor that patient carefully. It may also mean getting more labs. It may also mean actually eyes on the patient. We have seen sometimes there's been a number of things with telephones, interviewing, and different things, emails and stuff like that people have tried to do to improve compliance, which some of those things may need to be taken advantage of simply because it may be difficult to get the patient in depending on where they're at. So these are concerns that we have to deal with. All right, guys, let's take our first break of the day. Why don't you guys, let's come back at 1:15. All right, and then we'll pick up and talk about some more. One of the things we see is that as people age, we see certain things that tend to occur. We also see that these can be associated with pathology. So, and sometimes there's a combination. And one of the things is temperature sensitivity. So one of the things that we do see is that as older people or as people age, is that the ability for their body to adjust to temperature. And remember, for how we thermoregulate is basically a very common mechanism is going to be where that we basically vasodilate the blood vessels in the skin. So when we get too hot, we need to cool off, we get real red because what is happening is literally is that that your skin is basically becomes red because the blood vessels vasodilate. So blood flow goes up around the skin, and that helps the skin radiate. When you get cold, one of the things that happens is that you turn pale because your body vasoconstricts or closes those blood vessels down, which pulls the body to your interior to keep your core temperature there. Well, the biggest concern here is, yes, it's whether you're comfortable or not, but one of the big concerns we see with this is that if we're not thermoregulating properly, and this can occur with people that, as they get older, can occur with certain disease states that interfere with autonomic function. So one of the things that may happen is that if our body is adjusting, then we may be more susceptible to getting overheated. And then what happens is when we vasodilate, it drops our blood pressure. And so one of the things that we have to be concerned with in older people especially, or in people that have any condition that may affect their cardiovascular system, is that being exposed to temperature extremes, in particular heat, may cause them to faint. Not only does it cause them to faint, but it can put a stress on their cardiovascular system. So when we look at temperature sensitivity, one of the things that we see is that primarily is it's not only the environmental temperature, but also, for example, environmentally, for example, going out into the summer sun and getting overheated, and then they can develop heat stroke or they may faint. But the other thing we consider is, for example, being put into taking a hot shower. Older person goes in to take a hot shower, their blood vessels vasodilate excessively to try to cool them off, and then they faint. Or if it's combined with any drug that may lower blood pressure, or alcohol, or the combination of an alcohol, drug, and the temperature can cause that. From the cold aspect of it, the only thing that you really see somewhat is that what can occur here is that excuse me, is that basically the blood vessels may constrict so tightly that it can be painful. So we may see individuals that may have, if they have circulatory issues or diabetes, we may see sometimes that when they get cold, the blood vessels vasoconstrict so much that it can be extremely painful, and or it could affect their ability to use small movements, with their hands. Postural hypotension, as we get older, we're more likely to faint, especially with change in position. A lot of drugs that you will prescribe can cause orthostatic or postural hypotension. So we can see this also any condition, particularly, for example, cardiovascular disease can set up where that a person may be more subject for postural hypotension. And as you get older, one of the things that we're concerned about with postural hypotension is what happens if you faint and you fall and you break a wrist or break a hip. That can set up for some significant issues there. We do see, as you've heard me say over and over and over again, that renal function goes down as we age. But we also see that there are a lot of diseases, cardiovascular disease, diabetes, kidney disease. We see that as a consequence of those, that we may actually get decreased renal function. And when you add that to the age effect, it can be even worse. We could see hepatofunction going down. That occurs primarily, it can occur due to altered blood flow. It can occur, and that's usually what occurs with as people age and get older, is they get a reduction in blood flow. The other thing that happens is that we see is that an individual may have damage to their liver by drugs. So any drug that may be hepatotoxic, or any condition which may be attacking the liver, hepatitis, for example, alcohol, that can actually damage the liver. And so we get liver tissue that is replaced by scar tissue or fat tissue, such as a fatty liver. And then the other thing that can happen is we can get an alteration in receptor function. There have been some indications that as we age, our receptors may change. Certain drugs or pathologies, for example, if we have an increase or decrease in neuronal input, we may have an up or down regulation that occurs with these receptors. And so sometimes we have diseases that may attack the receptors. So these are things that can come into play that we have to be aware of. Okay? And again, sometimes is to try to quantitate how much damage or whatever is occurring. Sometimes that's real difficult. We may not be able to exactly quantitate how much is due to the disease versus how much is due to us getting older. Let's see. I lost my little. Let's see there. Okay, now let's move into the realm a little bit more that comes into play with what you're going to deal with, and with regard to really the psychopharmacological issues. Typically, we're seeing more the case of where that multiple drugs and regimens are being given with the treatment of a single disease. So when we start adding drugs, we stand a greater increase in side effects. We have a greater problem with compliance. One of the things to not overlook, even though you may be dealing with, middle class, college educated people, is when it comes down to the drug regimens or multiple drugs, we run into interesting scenarios. They may not understand. They may actually be confused. I think it was a study done a few years ago where that they took middle class, college educated people, and they gave them a prescription, and they said, tell us, read the prescription's instructions and tell us basically what this means. Most of them could do it. Then they had them actually do it. So in other words, they were to take the prescription and lay out when they were supposed to take the medicines. And what they saw is it was much more difficult, even though they seemed to understand the directions. They seem to have a problem with actually creating that. And Rebecca, what you're seeing there is, okay, so you got a 70-year-old, you got 17 meds per day. Let me give you an example of this. So we're really looking at multiple drugs and multiple drug regimens, okay? So if a person has a heart attack and recovers, they are usually put on probably 5 to 6 drugs right there. And idea as well, they seem to be doing well, I'm not going to change anything. So with a single incidence of a heart attack, that can add 6 drugs. And we know from the data that when you get 6 or more drugs, the chance of an adverse drug interaction goes way up, okay? So if you look at a person with diabetes, had a heart attack, maybe having depression, I mean, think about it. So with the heart attack, typically they're going to be put on aspirin. They're going to be put on another anticoagulant. They're going to be put on a beta blocker, typically an ACE inhibitor, an angiotensin converting enzyme inhibitor. With atherosclerosis, they're usually on a statin. I was trying to think what other drug, a beta blocker. So there's 6 drugs right there. With diabetes, typically they may be put on at least another drug, but maybe as many as 3 more. That's another 9 drugs. And then depression, and with depression, then you've got whatever drug you're going to use there. And if the person's hypertensive, which is not uncommon, you're usually looking at 2 to 3 drugs there. So, and then if this person is on all of those drugs on a regular basis, let's say they get let's say they have a respiratory sinus infection, then you're going to throw in an antibiotic, potentially a decongestant, and then it's not uncommon somebody would have their aches and pains, maybe just as them getting older, so they're taking a non-steroidal anti-inflammatory drug, maybe Tylenol on top of that. So it's easy to get those drugs quite a bit. So, and sometimes one of the things that happens, is that we see a lot of individuals that are, what we try to do is, the ideal situation would be once a day dosing, okay? The next ideal thing would be is that we dose associated with meals or a bedtime, because that's easy for the patient to remember. But when you start getting situations where a person is supposed to take this many drugs in the morning, take another drug at lunch, but the second dose of the first drug, these is what becomes very, very difficult, okay? And that can be very confusing. And then the patient will start basically taking the drugs when they think it's convenient, which may not be the best situation. And sometimes by taking some of these drugs, for example, sometimes we may tell them to take their antidepressant and a benzodiazepine at night, that would help them sleep. If they decide to take them during the day, then what happens is they may have some sleepiness issues during the day. Just like I told you about with the diuretic, is that we don't like to tell them to take that at night, and because it'll keep them up going to the bathroom. But on the other hand, some people would prefer to take it at night because they can go to their bathroom. So a lot of this may be an issue. And if they go into one of these dock-in-a-boxes, on the corner, for, let's say they have a sinus infection or something like that, they go into some of these places, and what happens is that they basically come out with another prescription, which, or 1 or 2 prescriptions, which can create even more issues. So it becomes a major issue. Multiple drug, and then sometimes we may have to have them take drugs every other day. We may have to take one every 3 days. And so the more complex the instructions, the less compliance that we get with these particular patients. The other thing is you've got multiple healthcare providers. You've got somebody usually a general practitioner is probably treating their cardiovascular disease. You may be treating their psychological diseases. another general practitioner, or they may have, for example, if they've had a heart attack, they may have a cardiologist. So we see multiple care providers, and we've even seen situations where when somebody is getting ready to have surgery, you know, they typically want them to um, stop taking their anticoagulants, you know, a week to 2 weeks from, you know, before the surgery. And we even have where some of the cardiologists don't want them to do that. So there's a lot of issues that come into play. There's a lot of egos, which I'm sure some of you, just out of curiosity, how many of you have run into an ego problem with trying to manage one of your patients? You guys are a little bit different because most of you are not prescribing at this particular point, but I can guarantee you that you will have more time with your patient. And a patient, we see patients sometimes are uncomfortable with giving, with bringing up an issue with their care provider because they're afraid that the person will get mad and won't see them anymore. So when we're talking about multiple healthcare providers, that's a big issue. Now, here's another one, multiple caregivers. When we're dealing with children, that's going to be, I've dealt with situations where that there was a child and there was a divorce. Mom was the young professional and insisted on the child had ADHD and had the child on the, on Adderall. Dad was not, he was more of a laid back individual, but was concerned. He did not like his children put on a lot of drugs. And so this went to court battle over this. It turns out I was called in because one of the concerns was the actual pediatrician who they were seeing who prescribed the ADHD drug. Her statement was, even though that child was born with a heart condition, her statement was the way you diagnose ADHD is if you give them an ADHD drug and it improves it, they have ADHD. Because this other testing that's done, the things that many of you might do, that was expensive and very tedious, and a lot of times it was not cost effective. So the dad didn't want it because he didn't want the child on these drugs because he had read about it's not good if they have a heart problem. The mom did, and so they went to court over that. So there was an issue. Multiple caregivers also may be when we see older people, if they're passed around with their siblings. Certain siblings may feel like they need medication and want that. Other siblings may argue they don't want to medicate it. Some siblings want them basically, pretty much knocked out, so they don't have to worry about them getting up and doing anything. The other big issue with multiple caregivers is the transference of medications and medication instructions from one to the next. We see big differences. I had a nursing home call me one time where that they had missed giving a client or patient basically their meds the evening before. And fortunately, the director knew me and she called me, and they were going to, the caregiver that was signed off for really managing it, the child that was in charge of this person, had told them, well, if they missed the drugs, just go ahead and give them the next time it was given. Well, they read me the list of drugs, and if they had given this woman the drugs from the night before plus the drugs in the morning, she would probably be sleeping for maybe 48 hours. So what I told them was that in any case like this is to call the prescribing physician. And I said, I can't imagine that the physician would tell you to double up the meds. One person told me the other day that the rule of thumb they use is that if it's more than one half-life, they just consider it a missed dose and don't do it. To me, the safest thing to do is to call physician up and ask the physician what they should do. He or she is the one that's prescribed, and that's the one that let them make that decision. But multiple caregivers, sometimes we have very little communication between them. Sometimes we have a lot of miscommunication with them. Can make a big difference. Also, with regard to observance of symptoms, Some caregivers are going to be very observant. Others are not going to pay too much attention to it. And you can sometimes get variations in what one's seen versus the others. And there may be variations with regard to what one sees, depending on how they interact with that person. We have drug disease interactions. So again, certain drugs are going to produce conditions which may exacerbate or may be a serious combination with the existing disease. And the more drugs we have, which tends to be the case, I mean, think about, so let me throw one other thing here at you guys, is that Rebecca stated that she saw a patient 70 years old on 17 meds per day recently. Let's throw in one other little point here, portion here. So they're getting these meds, and then on top of it is, what if it goes on one of the meds goes to a different generic? That can throw another big wrinkle in here, is a different generic may have a entirely different scenario. I don't know if I shared this with you, but my wife she takes Ambien. And one of the things that happened was we changed pharmacies. And when she changed pharmacies, unbeknownst to us, was there was a, they used a different generic. And so when she took the Ambien that night, both pills, I think, they're all quite yellow. They look very similar. But when she took the pill the night to go to, she could not sleep. In fact, she was up for almost 41 hours. And what we found was that there was a difference in the generics. As a result of that, what we see is that sometimes changing from name brand to generic, or generic to name brand, or generic to generic can cause another issue. That's the third point. I mentioned to you earlier about times when you look for things. So one is when you have a addition or deletion of drug. Two is when you change medications, change dosages. And three would be changing from generic to generic, changing from brand to generic, or even generic to generic. So we actually returned those pills, went to another pharmacy and got the generic that she was on, and she doesn't have the problem there. So I've heard of that book, Rebecca, but I have not read that one yet. So that's another thing. So we have drug-drug interactions, we have drug disease interactions, we have all sorts of issues with multiple caregivers, which can include whether multiple caregivers actually give the meds. Sometimes they don't want to fool with it, especially if the person is antagonistic to wanting to take the meds. We have multiple healthcare providers, which may actually become major barriers because they will not cooperate. It's so funny as we talk about all these, how important interdisciplinary medicine is. And the problem we run into is that many times interdisciplinary medicine works really well. The downside of it is that basically the interdisciplinary medicine works well as long as you keep the egos out of it. So that's an important thing. So these are all things that are real life issues that, in theory, we shouldn't work with it. Now, one of the things that I've done is I've identified certain drugs that seem to have real problems with regard to drug-related issues. And many of these we're using for chronic disease. And so it's another one that is, it goes across disease, but also with these. So I picked up three drugs in particular. There's digoxin, which is used primarily for heart problems. Typically now it's used for treating atrial fibrillation. However, it used to be used for congestive heart failure. I lost my train of thought there for a minute. And so I don't have it in red, but I do have the other two in red because these two you'll probably encounter more frequently. Warfarin is important because it is an anticoagulant, which, remember with anticoagulants, one of the things that we find is that if you don't take enough of it, then you clot. And if you take too much of it, then you bleed. So it's very important that we manage it. And warfarin works really well, but you have to monitor it very, very carefully. The other thing that we see is another drug which we see is lithium. You guys are very familiar with lithium. So when you're looking at drugs like this, and again, we're focusing on warfarin and lithium, these two, even though you wouldn't prescribe warfarin, if you have a patient on warfarin, there is so many problems that can occur with regard to that. By little changes in dosage can mean a big difference. A little change in dosage can mean you don't have enough protection and you suffer a clot. A little change in dosage could mean that you have too much anticoagulant on there and you could bleed. So, and with lithium, you guys know what happens is that if we don't monitor the lithium carefully, that we can have significant actions. Okay. One other point about this is that on the lithium, you see all these different drug names, and also with warfarin and lithium, these are two drugs that we do have generics for, and that sometimes an alteration in generic can create a problem. So now let's talk a little bit about some diseases associated or conditions and diseases associated in chronic disease. Let's start with depression, okay? There's several studies that have looked at different diseases, and looking at the different estimations, and again, how they measure depression varies quite a bit between these conditions. But one of the things is it's estimated that people with chronic diseases, that a significant number of these people do have depression, okay? 20 to 50% is the range that typically is shown, okay? So, and this shouldn't surprise you, because one of the things that you see is that somebody with a chronic disease, you've got a disease that's not going to be cured. You're going to have it probably the rest of your life, or you've lived with it for a long time. You've dealt with multiple visits to the doctor. The fact that it's not going to be cured is, can add to it. Multiple drugs, cost, limitation on your lifestyle and your quality of life, all of those could kick in there. Now, there is a big variation with regard to its prevalence, and that depends on the different issue, how severe it is, how quickly it progresses. That's what I mean by the pathophysiology. But one of the things that we see is that if a patient is depressed, they are more likely to visit their primary care physician. It's estimated at least 3 times more than non-depressed patients. Because there's one of the things that happens is as they're depressed, they actually become more and more, their symptoms seem to be more, and they keep thinking that that there can be drugs or someone else can fix it. So again, a lot of lost time at work, the illnesses. For example, we know depressed patients, the chronic pain is harder to manage. The pain manifests itself or seems to be worse in those particular patients. So that slide was a little bit out. Let's look at a few of these drugs that I've given you a list, and these are ones that you should sort of have in your mind. So one of the things that we see is, what drugs do we seem to have more drug-related problems, okay? So these are the lists that we picked out. Let me just point out a few of these to you. The ones in red I think are the most important. Anticonvulsants, why is it important? Number one is you're going to prescribe some of these. Anticonvulsants tend to be CNS depressants. You're going to use some of them as mood disorders. Anticonvulsants in general, tend to have more skin problems like Stevens-Johnson syndrome. Think about things like Tegretol. Think about lithium. Not lithium, lamotrigine. So these drugs, they also induce enzymes. So these tend to be a group that you want to be aware of. Antiarrhythmics, many drugs that correct one arrhythmia may produce other arrhythmias. We refer to this condition as proarrhythmic. So basically, they may correct. So you may start off to treat one arrhythmia and develop another one, which sometimes may be worse. Antipsychotics. Think about the antipsychotics that we have. We have one of the big things, EPS, tardive dyskinesia. We have that used to be the big one for the older antipsychotics. It doesn't seem to play as much. But now with the antipsychotics you currently have, one of the things you've got is the prolongation of the QT interval, so torsades. You may also see another thing with weight gain and diabetes. Okay, antidepressants. We have the issue about sometimes the antidepressants may make conditions worse. May actually, there's some believe that suicidality may increase. Sedative hypnotics, or the antidepressants, we also have those that can produce arrhythmias, the prolonged QT intervals, such as citalopram, I think one of you mentioned earlier. Sedative hypnotics, we have a concern of over, for example, over CNS depression and addiction. Non-steroidal anti-inflammatory drugs, those can cause renal problems. People tend to, since they're over the counter, a lot of people think they're pretty much, innocuous, but that's not the case. Anticholinergic drugs. These drugs, many of the drugs you prescribe will have anticholinergic symptoms that we have to worry about. A lot of the tricyclics do. So we worry about tachycardia. We worry about dryness of mouth, those type of things. Diuretics, very easily, they can get enzyme electrolyte depletion. Of course, narcotics, which that's not really the best term, because I found that a lot of people use any drug that's a scheduled drug as describing it as narcotics. And really one of the things that we find is that the narcotics is more of the opiate type drugs we see. With the antibiotics, one of the things you worry about is they can, many of the antibiotics may cause drug interactions. The histamine antagonists, we worry about cimetidine in particular. So these are just the ones I've got in red are the ones that I think are the biggest concern. But these are the class of drugs that have had a lot of drug-related problems associated with them. One is many of them, some of these like diuretics, NSAIDs, those are prescribed pretty heavily anyway. Let's go through these slides and then we're going to take another break. There'll be enough time for another break. The medications that can cause mental status changes, anticholinergics, and again, not only are, pure anticholinergics, because there are drugs that are antimuscarinic, but several of the drugs that you prescribe will have anticholinergic properties. Benzodiazepines should be well of. Buspirone has been associated with it. Caffeine. Caffeine is, we see a lot of caffeine being ingested today. You think about all the products that have caffeine in them. You've got coffees, and some of these coffees have got increased caffeine. You've got soft drinks with things like Mountain Dew. You've got a lot of these Rockstar Monster drink and things like that, 5-hour energy drink. We see a lot of people taking those in. Carbamazepine, you will prescribe corticosteroids, estrogen. These all have been associated with mental status changes. So if we have mental status changes, one of the rule outs that you should look at is looking at drug therapy and seeing if any of these drugs are present. If maybe there has been a recent prescription for one of these drugs, or there has been an alteration in dosage, would be one of the things that you would find. Here's some other ones. I picked up a few that you would prescribe, primarily monoamine oxidase inhibitors, narcotics. NSAIDs, I put that on the list mainly because of the, it is available over the counter. But we also have propranolol, which is a very common beta blocker that's prescribed for a lot of patients, cardiovascular patients. Selective serotonin reuptake inhibitors can do that, selegiline. So these are, again, drugs which potentially can cause mental status changes. And then the last ones, keep in mind, again, picking the ones that you would most likely prescribe, tricyclic antidepressants. But keep in mind, TCAs have been used as an adjunct to pain. So they can pop up there, valproic acid and Zolpidem. We see a lot of people using Ambien now. Okay. So this is a good break. Let's see. Let's come back at 5 after the hour. Just to give you an idea on schedule-wise, we're going to we'll come back at 5 after the hour. We'll go about another 20 to 30 minutes. We'll give you your quiz, let you go to lunch, and we'll go from there. And so let's come back at 5 after the hour.
Doctor, I'm going to run the attendance poll right now as well.
Okay, and Aiden, I'm going to send you, over this break, I'm going to send you the 3 quiz questions for this morning, okay?
Sure.
All right. The slide that shows a figure, it's not showing up on my, there it is. Okay. I was afraid that this didn't come through. This is sort of one theory that's come up with what happens to the elderly. And again, with the elderly showing a lot of signs with regard to adverse drug reactions and having a lot of chronic diseases. So with both the combination of aging and the disease, what we seem to happen is that we get impaired organ function, which can lead to also maybe as a consequence, but can also lead to multiple disease states. So we can have, just as a result of age, for example, our kidneys are going to decrease and so forth, or we have multiple diseases, which results in impaired organ function, or the diseases cause the impaired organ function. So then what happens is we run into, this is sort of what I talked about before, where that when you have multiple diseases, typically they're going to be treated with multiple drugs. And as we talked about, once you start doing multiple drug administration, you start getting altered compliance because people get confused. Older people sometimes will not take certain medicines they don't like, or sometimes that their peers will tell them they don't think is necessary. So when you get altered compliance, or like one person did, she was a little old lady that basically she would take her medicine only when she went to the doctor. And when he would ask her, how are we doing this morning? Or we've been taking our meds? Her response was constantly, oh, took them this morning. Well, took them this morning meant she took them that morning, did not mean that she was taking them every morning. So the doctor just assumed that she was taking them as prescribed, and was basically making that assumption. And when the drugs weren't working, the idea was, well, she needed to have a change in drug, which wasn't the case at all. The other thing we find is sometimes a drug is expensive and another drug is not, so they may buy the less expensive drug. So there's a lot of different reasons, but net effect is by altering compliance, not following what we see, that can cause an adverse drug reaction. We can see just the fact, again, as I told you, that the chance of an adverse drug reaction increases when you get 6 or more drugs, significantly increases. We see that is typically what occurs. But the other thing we find is that when we get impaired organ function, that can in itself cause adverse drug reaction. Take the kidneys. So when the kidneys aren't functioning, we get a buildup of drugs and we get that effect occurring. We find that the drugs, when your kidney or your organs aren't functioning readily, your homeostatic regulation gets impacted, and therefore your body can't adapt to the effects of the drug and the disease. And in fact, many times we may find that the drug interferes with the homeostatic regulation, and sometimes the homeostatic regulation set points have been altered according to the disease. So what your body's doing is actually fighting the effects of the drug. And then the other thing pharmacokinetically is that with altered function, we can get altered drug concentrations at the receptor. So there's a number of things that contribute to ADRs in the elderly, but you could change this slide to read it, factors contributing to ADRs in patients with chronic disease. Now, let's talk about some of these specific conditions, how they may affect it. So World Health Organization mentioned that visual impairment and blindness was one of theirs. And these statistics are a little bit old. I didn't update them, but I mean, it's estimated that about 246 million people are considered to have low vision. About 30 million people are blind. There should be an L there. We see cataracts are a leading cause of problems. And we see that there's a large portion, ophthalmologists love this, that we see that we can either prevent or cure visual impairment. I mean, you think about, like, I had LASIX for years. I was nearsighted. Bottom line is LASIX, I was, without that, without having a problem once my eyes were corrected. So we see a lot of things, and the cost has gone down for doing this. But just even with corrective lenses and glaucoma surgeries and glaucoma screening, all of that has had a significant impact on it. When you look at the major causes, we see uncorrected refractive areas, people being either near or farsighted or having astigmatism, cataracts, glaucoma. We've increased our screening of glaucoma. And with the population that's usually affected, it's usually over the age of 50. Significant portion, 65%, are considered to have a significant issue there. So what concerns do we have with your patient that may have blindness or being impaired? One is they can make an error in taking their medication, not being able to read the label. So if you don't explain it to them, and the pharmacist doesn't explain it to them, and a lot of people go by and they want to just pick up their meds and head on out, then that can be an issue that is significant there, okay? So picking up the wrong med, for example, if they're using these little pill pockets, one of the things is, I had a lady that thought she was taking her antihypertensive medication. She ended up taking her Ambien and then ended up driving. So that was an issue. We also have medication interactions. We see cholinergics and anticholinergic drugs can affect vision. They can affect, for example, anticholinergics can affect a person's ability to see far. We know that beta blockers can sometimes make increases in intraocular pressure. So there's very significant drug interactions that can occur with a number of drugs. But probably the biggest thing we see with many of these patients is simply a potential for taking their medication wrong or picking up the wrong pill. They're not able to see, sometimes they may not be able to determine if they've got the right medication when it's prescribed. Let me check something real quick. All right, so I was just checking to see. Let's see if we can get through the antidepressants. So the next group we'll look at it, or not antidepressants, the next group we're going to look at here is going to be disease, is cardiovascular disease. Considered probably the #1 cause of death. Really what you see a lot of times, it's is it cancer or cardiovascular disease who's gaining the benefit here. But we see a lot of people that die primarily either due to heart attacks, so secondary to coronary artery disease, or they have a stroke. And so significant amount of data, and again, I'm not asking you to regurgitate any of these statistics, just to give you an appreciation of the patients that are affected. If you look at something, there's been some interesting studies, and these have been around for a while, but it's really not been acted on. If you look at the cumulative mortality for depressed and non-depressive patients after they have an MI, this study by Fraser Smith was pretty revealing. What we saw was a significant increase in mortality in patients that were depressed compared to non-depressed patients. So, we saw this increasing on your x-axis is the weeks post their myocardial infarction. And one of the things we see starting around, 6 weeks afterwards, there's a pretty good increase in the mortality rate. Some people have argued the reason for this is that the heart attack scares them. Again, 93, we know that quality of life and everything has improved quite a bit. So even with this, we know that there's still some increases, and it's actually raised some of the cardiologists' awareness of trying to address this. So what they've seen in patients that have comorbid depression, that myocardial infarction after valve surgeries or rheumatoid arthritis, there's increased mortality. Not only is there increased mortality, but there's increased morbidity and disability. These people just don't get back to where they were. And we see that there's increased healthcare utilization, which means greater cost. One of the biggest things is we find, and I've seen this over and over and over again, especially after people that have had a heart attack, is that the first few weeks they're scared. So they are very, they adhere to treatment very well. After about 6 or 8 weeks, what we find is it's like it's past the time. So what happens is they quit taking their meds, they quit exercising, they quit watching their diet. As one of my students once told me, her dad had a heart attack, and she was on him about, his eating and stuff like that. He was overweight and so forth. And one of the things that happened is that she finally got him to eating these lean cuisines. And she was so proud. She was telling me about it. She was actually bragging about, how she had done everything to get him to do this. And after she went back home, and he was telling her, he said, these lean cuisines aren't that bad. He said, the only problem is you got to eat like 3 of them to get full. So, he completely lost out on this concept. But we see people doing a number of things with regard to this, is they just quit following the treatment. It's almost like that, I see people dropping off of exercise. I see their dietary changes and so forth really decrease, and that probably adds to the increased mortality. So one of the things you have to be aware of if you have these type of patients is that they may stop doing what you've asked them to do. We do know there's been enough studies that suggest that if you're depressed, there is a greater risk for an additional coronary artery, for your disease to progress and myocardial infarction to occur. And it's estimated about 15 to 23% of the myocardial patients actually have major depression, and that there is a significant increase in risk of death after an MI. One of the things that we know is that there is increased activity of the hypothalamic pituitary axis and the sympathomedullary axis, which means your sympathetic nervous system seems to be working over, and that can increase the stress on the cardiovascular system. When we look at inflammatory markers, which we do know cardiovascular disease does produce inflammation, we see that's these inflammatory markers like cytokines, C-reactive protein, those are elevated. People's platelet aggregation is increased, and that gets even worse if they're not taking their anticoagulants. So they're more likely to develop a clot. We see people significant amount of stroke, depression after stroke. And a lot of times people are depressed because they either think that they're going to have another stroke, or because of the liability that occurs, or their loss of productivity and change of quality of life. So we do see that if there's depression after the stroke, that morbidity and mortality both is increased. So in 2003, Canton came up with this model that basically talked about these changes, so that there could be things in your life, genetic vulnerability, various life events that could lead to maladaptive. But if you look at the main portion of this, it sort of fits with regard to the cardiovascular, that when we have depression and anxiety disorders, one of the things that happens is that we also seem to have, or these patients also seem to have certain risks for chronic disease. They're overweight. They have a sedentary lifestyle. They may do things like smoke or excessive drinking. Many times chronic stress metabolic syndrome can occur. So what happens is that they're stressed, that results in things like diabetes, their sympathetic nervous system and so forth not working. So that sets up for them to develop cardiovascular disease, neurological disease, diabetes, neurological, primarily stroke. So what we find is that when they develop this, their symptom burden goes up. They start worrying about one thing after the other. They become functionally impaired because, one, if you're obese, sedentary lifestyle, smoke, you're not going to be that active. It's hard to breathe. You just don't feel like wanting to do it. This can lead to changes in your brain that can create some secondary illness. For example, diabetes can cause cardiovascular disease. Cardiovascular disease can lead to diabetes. So what happens is that you develop this issue. And what's important is when we're dealing with, and this is the main thing I want you guys to get out of this slide, is this chronic medical disorder is we've got to get patients, regardless of what the chronic disease is, we got to get them collaborating with their healthcare provider. This slide was written, it said MDs, but you could use healthcare provider, whether it's you, many times it's multiple healthcare providers. We need to get them exercising. We need to get a proper diet, nutrition going. Make sure they're staying on their meds, taking them like they should be. And at the same time, we're monitoring them to see if there's any problems with their meds or if there's any exacerbation of their disease. Things like quitting smoking, cut down, or quitting drinking. This seems to work is to develop this self-care model, but it involves an interaction and interdisciplinary approach. What we find is that when people have anxiety and depression, we find that it's pretty common in patients with cardiovascular disease, people with hypertension. After all, with hypertension, you've got a disease that's not curable. We know that down the road that it's going to cause problems. It typically gets worse as you get older. We know with coronary artery disease, a lot of times that gets older. It means you got to change your diet. You need to exercise. But what we find is that when they have untreated disorders like anxiety and depression, or even other psychiatric disorders, the prognosis of cardiovascular disease is actually worse. The problem we've run into is getting the cardiologists and the general practitioners that are treating these patients in contact with psychiatrists and psychologists. You know, that's one of the things with regard to you guys that I see this being more of a viable approach. Psychiatrists, it's very difficult sometimes to get them to talk to the cardiologist. And if you look at the literature, is the literature that shows this is only just recently, I mean, I say recently since around late 90s, 2000, has sort of touched on some of these issues. But we do know that with the new drugs, especially the selective serotonin reuptake inhibitors, that these drugs work pretty well in people with cardiovascular disease. Now, we have to be careful. For example, as one of you mentioned before, drugs like citalopram may be arrhythmogenic. So we still have to make a decision on which patient we're going to look at and which drugs we give and still monitor that pretty closely. We do want to avoid the tricyclic antidepressants. They tend to create orthostatic hypotension, which drops blood pressure, sets up for somebody potentially fainting. But another thing is their anticholinergic actions can actually increase heart rate and potentially increase blood pressure. But one of the advantages that we've seen is that some of the selective serotonin reuptake inhibitors actually may protect against cardiovascular risk. One of the things we know by elevating serotonin, that tends to attenuate activation of platelets, so we're not as likely to clot. And we also see that that reduces the storage of serotonin in the platelets, mainly because it is decreasing that serotonin. So that decreases aggregation. The antidepressants, you know, when people feel better about themselves, they're more likely to do things. So if we get them out of that depression, we have to be careful with the tricyclics because they can be arrhythmogenic, mainly because of their anticholinergic aspects and the orthostatic hypotension. There's been a couple of interesting studies. Again, not going to ask you to cite these studies, but the Sad Heart study, like that, was dealing with depression and people after myocardial infarction. So what they found was sertraline was safe and effective after a myocardial infarction and actually may be beneficial by inhibiting platelet aggregation. There was also the Enriched study in 2005, another major study which showed that people on SSRIs that had had myocardial infarction showed a decreased mortality and had less likely to have a secondary myocardial infarction. So those, I'm looking at, So let me cover 2 more slides, we'll take our break. So those studies actually gave us a lot, and you would anticipate probably most of the SSRIs would be similar. Again, the concern would be with citalopram and escitalopram. You just want to be careful with that. What we do know is that when people are on these drugs, some of the CVS medications, cardiovascular medications, we want to be careful about because they could interact with some things with some of the SSRIs, is diuretics can cause hypovolemia. Be careful about that. They can cause some orthostatic hypotension. But in particular, one of the big ones is we got to be careful about a patient on lithium. So we don't want to use diuretics with a patient on lithium, okay? Beta blockers can produce some CNS depression. We have to be careful about that. CNS acting drugs, clonidine, methyldopa, depression is a concern, so we really want to be careful. And reserpine is a drug which is used very, very rarely now, but these last 3 all act in the central nervous system and could really exacerbate depression, so we would want to avoid that. Don't necessarily have to avoid the beta blockers, but we do need to be cognizant that they may produce some depressive actions. We want to be careful with psychotropics with cardiovascular disease. Stimulants can elevate blood pressure, can increase heart rate. Some of the antipsychotics can prolong the QT interval. And then, as we've mentioned before, the SSRIs, citalopram in particular, escitalopram would be another one, could produce a prolongation of the QT interval. So we can use these drugs, but we still have to be cautious with them. Overall, it seems to improve conditions, but again, have to be careful and monitor carefully with these particular patients and all. All right, so we're at a good place for you guys to take your break. Before you go, Aiden is going to put up the quiz, and the thing that we're going to run into, we'll come back to, is that we'll come back on the hour at, sorry, not on the hour, at 1 o'clock. We'll get back from lunch, and we will go over these quizzes. So Aiden, if you'll put these up when we get back, then we'll go over them. If you guys want to just look over what I gave you and just double check to make sure you don't have any specific questions. And then we're going to move through some of the other chronic diseases and a couple of other things this afternoon. Does anybody have any questions?
Right. I'll keep the poll on for 10 minutes, Doctor.
Okay, sounds good. I'm going to log out, and I will see you guys at 1 o'clock.